Hi, my name is Jessica Kenny, and I'm an assistant professor at the University of Colorado School of Medicine and a licensed psychologist at Children's Hospital Colorado. I'm the lead author on the paper addressing adolescent suicidality in pediatric primary care. And on behalf of my colleagues, we're excited to share more about our paper published in the Journal of Developmental and Behavioral Pediatrics. In this study, we examined prevalence rates of reported suicidal ideation in adolescents in a pediatric primary care setting, characterized recommendations and interventions given by primary care providers and integrated behavioral health clinicians in response to reported SI on the PHQ-9, and then identified factors associated with a decrease in frequency of suicidal ideation at follow-up visits. The setting of our study is a large urban residency training pediatric primary care clinic housed within Children's Hospital Colorado, affiliated with the University of Colorado School of Medicine. We serve a predominantly low-income, diverse population and conduct about 34,000 annual visits. This setting includes a fully integrated behavioral health team. Over the course of a year and a half, 2,673 adolescents were seen for a primary care visit, and of those eligible adolescents, 2,107 completed at least one PHQ. We coded all of the PCP and behavioral health notes for the adolescents with reported SI during our study and used conventional content analysis and coded an atlas with 3 coders until we achieved reliability. The study has several noteworthy findings. 140 or 7% of our overall sample reported SI within the past 2 weeks. About half these visits were sick or follow-up visits, which points to the importance of universal screening at all visits, not just well-child checks. Interestingly, of the 140 who had elevated SI, 58 or 41% did not have an elevated overall PHQ, which points to the importance of treating adolescents with SI as a distinct group to identify, characterize, and intervene on, separate from those with overall depression. Findings associated with a reduction in SI at the follow-up visit. For PCPs, it was referring to behavioral health and family navigators, so referring to their resource partners. And for BHCs, it was conducting a risk assessment, completing a safety plan, explicitly involving caregivers in the visit and recommendations, sending the adolescent to the ED when indicated, and referring to family navigators. And family navigators or community health navigators are partners in clinic who help a family with resource or social determinants of health needs. The study is important for several reasons. There's no evidence that screening for suicide directly prevents suicide. However, proactively asking about and acknowledging suicide is an important first step and mechanism that allows for intervention and provision of resources that we know reduces suicide and suicidal behavior. Universal screening is a way to address adolescent suicidal ideation at the population-based level. Again, adolescents with suicidality are not necessarily the same as adolescents with depression, and they need to be conceptualized and treated as such. Integrated behavioral health and family navigators are crucial multidisciplinary primary care providers to involve in practice transformation. And lastly, there's evidence that safety planning alone does not reduce suicide. Our results suggest that involving caregivers explicitly may add an important piece to safety planning and improving effectiveness. We want to see this study for several reasons. Primary care is frontline mental health care, the main port of entry into the healthcare system, and where the majority of individuals with SI and other mental health concerns are seen, not in traditional outpatient behavioral health settings. It should therefore be resourced as such. We see the full continuum of mental health needs in primary care, including health promotion and prevention, early intervention, and risk assessments, crises, and safety planning are also a huge part of what we do. There are several national mandates to screen, identify, and address depression and suicidality in primary care. It's important that PCPs don't feel alone or overly burdened with this, and we wanted to provide guidance on what PCPs can do and how they can be assisted by multidisciplinary partners in reducing adolescent suicidality. I'll leave you with a few call to action items. First, implement universal adolescent depression and suicide screening in pediatric primary care. Understand that adolescents with suicide are not necessarily the same as adolescents with depression. Utilize multidisciplinary partners when responding to suicidal ideation. Engage the caregivers and family in risk assessments and safety planning, and build partnerships and referral networks with community partners. Thank you.